is Jordan Kyongo, he holds a master's degree in molecular biology. He's also an MPH, he also holds an MPH and is a PhD candidate. He's a member of the Kenya National PrEP Technical Working Group and the Kenya AIDS Research Coordinating Mechanism. He will talk to us, his presentation is entitled, How Long Will They Take PrEP? Oral Pre-Exposure Prophylaxis Retention for Female Sex Workers, MSM, and Young Women in a Demonstration Project in Kenya. Jordan.
Thank you. So thank you very much for this chance to present our data, again, on behalf of many people, and also to you all for taking time to come and listen to the different presentations that are being done today. So I'll very briefly take you through the background of the talk I'm about to give you, and also then give you the procedures that we did as part of the demonstration project, give you the retention results, and then explain a few reasons why some people stayed and some people left the project, and then we can have a very quick reflection on what this means for real-life implementation. So in 2013 in Kenya, and the context of this is PrEP was not yet rolled out. There were no guidelines. The guidelines that Dr. Kinuthia has just shared, they were not yet there. We did a feasibility study among female sex workers, men who have sex with men, and young women. And among the many questions that we asked, one was, would you be willing to take PrEP? So remember, this is a theoretical setting, so there's no PrEP, there's no guidelines. And an overwhelming majority of them said yes. So for all the three populations, over 80%, most of them say they will be willing. Keep your eye on the young women percentage at the very end, because that's relevant later on. So we then went ahead in 2015 to do a demonstration project. And in this project, we were providing PrEP in private and government facilities, looking at if it is feasible to deliver PrEP in real-world settings, looking at different populations, so the same three populations. And we're able to screen and find a total of 2,100 plus individuals who are eligible for PrEP. That was our target population, that was our target for this project, in 3 different counties in Kenya. So what did we see in terms of retention? And this is where it gets juicy and maybe in not too nice a way. But before we get there, one of the things that was supposed to happen then is once you get screened and you're found to be eligible, and that was during that first visit, then we would give you 2 weeks, at which point you would have time to think about whether you really want to take PrEP, but we'd also have time to do the blood test. So look at creatinine testing clearance, looking at hepatitis B and C, whether you're infected before we initiate you on PrEP. And then after that, you come back after 2 weeks, and then you'll be initiated onto PrEP. And then you do follow-up visits every month up to the 4th month, where if you are a good adherer, you'd be given the option of taking PrEP for 3 months, or still come back after 1 month if your adherence was not very good. So that was the structure of the program. And you were supposed to be followed up over a period of 1 year, and then exit the study at the end of 12 months. So to the results. So if you focus on the first set of results, either the female sex workers, and if you focus on the first one. So the first bar is the total number of people who were eligible for PrEP. They were screened. And then the next bar refers to those who were initiated. So you can already see after the screening, 2 weeks later, we already lost a number of people who did not come to initiate PrEP. And then if you take this as the total number of people who initiated PrEP, by month 1, you only had 40% of them still taking PrEP who came back for the next dose. And that number continuously decreases up to, this is data until 6 months later. And the trend is the same for all populations. But the reason why I told you to keep an eye on the 85% is because you can see out of the ones who are eligible for the young women, the same percentage, slightly higher, came back for PrEP. So young women are willing to take PrEP. When they say they want to take PrEP, they actually are willing. This was in 2 different time points. But the interesting thing is that immediately you see a huge drop for the young women. So they are very willing, they start, and 1 month later they're out. So what is it that is causing them to drop out that fast? And the reasons are some of this. So I'm so glad that I came after the 2 presenters who came, because a lot of these things are shared across different projects. And side effects were big. And one of the reasons they said is, as you see there, is they say they had nausea, headaches, dizziness, running stomach, darkening of the skin, weight gain, loss of appetite. And they report this over a period of 1 day up to 1 month. Then if someone had a reduced perception of risk, then they dropped out of the project. And if they had a bad encounter at the facility with healthcare workers, they also dropped out of the project. And then there were a lot of myths and misconceptions. So remember, this is between 2015 up to 2017 when PrEP was rolled out in the country. And some of the misconceptions were around the fact that PrEP would make you impotent. It was a way of eliminating Kenyans. It was being used as a way of family planning or birth control, and that it even reduces your sexual urge. So you do get a lot of misconceptions about PrEP. Population-specific reasons for dropping out for female sex workers and MSM, so we group them here as key populations, was one around the packaging. And the concern is because it is an ARV, so people fear that if I'm seen with it, I'll be thought to be HIV positive. The pill color, we were using Truvada for the study, and in Kenya, there's a date rape drug that is blue in color. So the female sex workers will be afraid, and they would think that if I'm seen with this pill, then it will be feared that my intention is to actually drug someone or my clients. So because of this, they were afraid of taking PrEP and staying with PrEP. And then some say the pill was too large. Some people had challenges accessing the sites as well, and these were two different reasons. So, for example, it could be that because the KP were very mobile, it's a mobile population, so, and at this point, PrEP was not available everywhere, but also issues to do with transport. So, like this quote from this MSM who says, sometimes I'm going for a job far and I do not have transport that will bring me. I'm supposed to come, and so the transport that will take me back to the job and getting it is hard. So there were issues because we were not giving any reimbursement for these populations who were accessing here. But also during the first visit, the procedures were very tedious. We were doing a lot. It was taking a lot at the facility, so people were dropping out because of that. For the young women, there was the risk of social harm, but not just risk. There was also actual social harm. You see this young woman who says, when I informed my husband, he refused and told me that he should not find me using it. So I started taking the drug in secrecy. When he came to know about it, when he saw that bottle, he beat me to the extent of destroying my nose. So PrEP actually results in violence sometimes for the users. But apart from violence, there's also the risk of stigma for these young women. So these are some of the reasons why you saw that initial drop that you saw. And there's also lack of support from their partners, so their sexual partners, from their peers, but also from their guardians and parents. So the example of this young woman who stays with her aunt says, that was hard. I thought to myself, what will I do now? I was even afraid to tell my aunt because I did not know how she will take it. So I just declined. I had no otherwise. That's a very Kenyan saying. They say, I had no otherwise. For the few that stayed, why did they stay? The reason why they stayed was the opposite of why some of them dropped. So because when they had support from either their peers, their guardians, or their partners, then they stayed. So remember, we've talked about a case about someone who dropped because their partner was against them using PrEP. And this other one is they say, I took the drugs, I had to explain to my husband, if you find this bottle, it's not for the drugs you think that is for the virus. It is just for taking it. That way, the way I can just be taking Panadol as a painkiller, now he has understood when it comes to that time and he sees me taking a tablet after opening it, he doesn't care. So there is a place for explaining, and after understanding, then you get a supportive environment for the person to continue taking PrEP. Then also people who came to the facility to get other services other than PrEP, that was a motivator for them to stay. And then lastly, people who had social responsibility. So they were either taking care of their siblings or their children. They were willing to take PrEP because of their responsibility in the society. And then for all populations, if they had a positive encounter with the facility, with the healthcare workers, then they stayed. But also those who knew their risk, so similar to what Dr. Kinuthi just mentioned, they were willing to stay. As a quote from this female sex worker said that because of having multiple partners, having unprotected sex, you do not know their status. Like even those four, I only knew the status of one person, and they do not want to come to the clinic to test. So the person decided to stay and take PrEP. So finally, what does this mean for real life? At an individual level, and these are just thoughts and reflections based on our work, PrEP is a choice. So we give people PrEP, but we also give them many prevention options. And people can decide to take PrEP, they can decide to use condoms, they can decide to use any other options they need for prevention. So we need to keep that in mind. I had a chat with Manju on Saturday, and one of the things she said, and this is not a verbatim quote, but it was something in this line, that the end game is HIV prevention and not PrEP use. So keep that in mind. Someone may refuse to take PrEP, but they may take condoms, and that's okay. They don't necessarily have to take PrEP. But the other thing is that my director always asks us, if you keep someone in a prevention program for 2 years on PrEP, would you consider that success? wouldn't it have been better that your prevention program reduces their risk so that they can actually get off PrEP because their risk has actually gone down low? So one of the things that we need to be tracking as we provide PrEP is risk. And risk both objectively but also subjectively. Do the people feel that they're at risk? And are the metrics that you're collecting showing that they're at risk or not at risk? So the other thing that we obviously need to do is just provide information to address the myths and misconceptions, but also the side effects that they face that are real. Then at the health system level, we need to continuously train our healthcare workers. And this is important because there's a lot of information that comes out, but also important, this second part that talks about values clarification. We are doing a study as part of the Options Consortium. I have to give a shout out to my people. That where you see, even though people have knowledge about PrEP, they may have attitudes that are negative towards providing PrEP to specific populations. So it's important that we train our healthcare workers not just to give them knowledge, but they have the right attitudes in terms of providing PrEP to all populations that need them. And then secondly, and this is important, that we need to think about providing PrEP in a differentiated kind of manner. We are used to providing it at facilities, but we need to think beyond the facility and think about, should we be following people where they are, taking it to the community, taking it to the hotspots, and being very flexible about the times that we provide. So for example, for us, the key populations would rather come in the morning or in the evening. The young women prefer to come during the day. So be very flexible about how you provide it. And then finally, and this to me is one of the most important things that we forget, is that we provide PrEP to an individual in a facility. Then this young woman, this female sex worker, this MSM, goes to a context that is different from the facility. So you give it to a young girl and they go home and they'll be having to take it where there is a partner, where they have their peers, where they have their guardians, in a context of a school setting. And if the information there is wrong, then these people will not be able to take PrEP. So the thing that I think, and I'm trying to push for, is that we need to provide interventions at community level so that people have the correct context within which they can be able to take PrEP and take it well when they need to take PrEP. That's important. And then the last point in this slide is that there is need for increased community education and engagement. As Mary Aikenhead from the Gates Foundation once said, let's make PrEP famous and make it easy for people to take. So as part of the Kenyan team, there's a lot of work that we're doing that speak to this. So if you have some time, visit the sessions that are highlighted here, including the posters and the talk on Friday that will focus on PrEP provision for young people as part of Team Kenya. And then this work is, as I said at the beginning, done by many partners, and it has been funded by the Gates Foundation. We worked very closely with the community organizations that are listed here in terms of providing them together with SWAP and other providers. Thank you very much.
Thank you very much. We have time for just one question. Mic number 5.
Hi, thank you. I have a question. Do you know how many people got infected with HIV among the people you work with? Because you said PrEP is just one strategy among others, but are these people using the other options of prevention? Thank you.
Yes, so we have some data about condom use and other prevention options, so we do have some strategies. We had a total of, out of the number that were recruited, a total of 4 people who were infected with HIV, but we also know that they were not taking PrEP because they did not come back. They came back to our facilities for services, but this was after missing out for 3 months or much longer. So no one who was on PrEP got infected. Yes.
And number 2, please make it quick.
Hi, hello. I'm Olga Denisuk from Alliance for Public Health Ukraine. So for the retention slide that you showed, did you calculate participants who didn't report having a risky behavior period for the follow-up visits, so they stopped using PrEP because of that?
Yeah, so we have data on risk. So we're collecting at every visit, we're collecting risk. But the slide there was just showing for all participants. And it is drop off from PrEP. If we know we gave you PrEP for a month, if you do not come back, then for this purpose of this analysis, we considered you to have dropped off. But we do have data on risk. And you actually do see for some populations that the ones who stay, their risk actually reduces over time. And then you also have better adherence over time. So there's a lot more analysis that I didn't show in this presentation. Yeah.
Thank you.
Thank you very much. Thank you.